Welcome back to the deep dive. Today we're taking a really close look at the body's largest organ, the skin.
Yeah, it's fascinating stuff. The proper term, is the integumentum,
And it's huge. Our sources say it's something like, what, 16% of our total body weight?
roughly. Yeah. And think about its role. It's this massive barrier, our main interface with the world.
Our first line of defense, really.
Absolutely.
Yeah.
Against, well, everything, microbes, sunlight, getting bumped around. And what gets me is how dynamic it is.
Always shedding, healing.
Regenerating. It's constantly turning over. It's quite remarkable.
Which is exactly why we're doing this deep dive today. Our goal, really, is to unpack the source material, connecting the skin's structure, all those complex layers and cells, to how things can go wrong. The altered health states.
Right. We want to make sure the key terms and concepts are clear so you can link the anatomy to the pathology. It's about making those connections stick.
And the skin itself often gives us clues about what's happening deeper inside, doesn't it?
Oh, definitely. The sources point this out clearly. Think about the malar rash. They sort of butterfly shape across the face.
Classic sign for lupus, SLE.
Exactly. Or like a bronze tint to the skin might signal Addison disease. And jaundice, of course, that yellowish color.
Big warning sign for liver problems.
Yeah. So the skin really is a window into systemic health. It's a powerful diagnostic tool if you know what to look for.
Okay, so let's get into the structure. How is this amazing organ actually put together? What are the main layers?
So fundamentally, we're looking at three main layers,
Mm-hmm.
but it's important to remember they aren't uniform everywhere. Like the skin on your palms is way thicker than on your eyelids.
Makes sense.
So the outermost layer, the one you see, that's the epidermis. It doesn't have its own blood supply. It's avascular.
Okay, epidermis on top. What's underneath?
Beneath that is the dermis. This is the connective tissue layer, full of collagen, blood vessels, nerves, all the support stuff.
And holding it all down.
That's the subcutaneous tissue, sometimes called the hypodermis. It's mostly loose connective tissue and fat, kind of anchoring the dermis to whatever's underneath, like muscle.
You mentioned that epidermis is avascular, so how does it stick to the dermis and get nutrients? There must be something holding them together.
Ah, good point. That's the basement membrane. It's this super important, thin, kind of adhesive layer. Think of it like specialized glue between the epidermis and dermis.
And why is it so crucial clinically?
Well, two big reasons. First, when you get friction, like from shoes rubbing, it's this zone that separates, leading to blisters. That space fills with fluid.
Ouch.
Second, it's a key site in certain autoimmune diseases. Immunoglobulins can deposit there, attacking the anchoring structures. That causes the layers to pull apart, leading to conditions like bullous pemphigoid. So yeah, the integrity of that membrane is vital.
Okay, that really clarifies the overall structure. Now let's zoom into the epidermis itself. You said four main cell types. Let's start with the majority player, the keratinocyte.
Right? They make up about 85% of the epidermal cells. And their whole deal is protection. They're constantly migrating upwards.
And they make keratin, right? That tough protein.
Exactly. They produce keratin. And this whole process, as they move up through the layers, is called keratinization. It's like a journey through 5 distinct zones or strata.
Okay, take us through that journey. Where do they start?
They start deep down in the stratum germinativum, or the basal layer. These are the stem cells, basically. They're constantly dividing through mitosis, creating new keratinocytes.
So the factory floor.
Pretty much. Then, these new cells get pushed up into the next layer, the stratum spinosum. Here, they start to differentiate and develop these little connections, making them look kind of spiny under a microscope. That's why they're sometimes called prickle cells.
They must need to hold on to each other tightly.
They absolutely do. And that's where you see structures called desmosomes, which are like strong rivets holding cells together, and also tight junctions, which prevents stuff from leaking between the cells.
Okay, so basal layer, spinosum, what's next?
Next up is the stratum granulosum. This layer is really key. The cells here are synthesizing a lot more keratin, but they also start producing these lipid-filled sacs called lamellar bodies.
And this is where the waterproofing happens.
Exactly. They release these lipids into the spaces between the cells, creating that crucial water-impermeable barrier. It's what keeps moisture in and, bad stuff out. Life-sustaining, really.
Wow, okay. And after the granulosum?
After that, there's a thin, almost transparent layer called the stratum lucidum. You really only see this clearly in the thick skin, like on your palms and soles.
Right. And then finally...
Finally, they reach the top. The stratum corneum, this is what you actually touch. It's made of multiple layers, sometimes 15, sometimes over 100 on your heels of dead, flattened, completely keratinized cells. They're basically just tough protective scales.
And how long does that whole trip take, from birth in the basal layer to being shed?
It's pretty consistent, usually takes about 20 to 30 days. And if that timing gets messed up either too fast or too slow, that's when you start seeing skin problems like psoriasis or certain types of scaling.
Fascinating. Okay, besides the keratinocytes, what other cells live in the epidermis? Let's talk about pigment melanocytes.
Right. Melanocytes also hang out in the basal layer. Their job is to produce melanin, the pigment granules that give skin its color.
And there are different types of melanin.
Yeah, primarily two forms. Eumelanin, which is brown or black, and it's really good at protecting against UV damage, and pheomelanin, which is more yellow or red.
So is the difference in skin color just about having more melanocytes?
That's a common misconception. Actually, dark-skinned and light-skinned individuals have roughly the same number of melanocytes.
Really? So what's the difference then?
It's about how much melanin they produce, the size of the melanin granules, the melanosomes, and how they're packaged and transferred to the keratinocytes. In darker skin, the melanosomes are larger, more numerous, and transferred individually. They form kind of a protective cap over the keratinocyte nucleus.
So it's more about the efficiency of the pigment production and distribution.
Exactly. It provides much better protection against UV radiation and, consequently, skin cancer.
Got it. Okay, next cell type. The immune link. The Langerhans cells.
Yeah, these are the epidermis's resident immune surveillance cells. They're antigen-presenting cells.
Meaning they grab invaders.
Right. They pick up foreign antigens, process them, and then they actually migrate out of the epidermis to the nearby lymph nodes. There, they present the antigen to T cells, kicking off an immune response.
And the sources mentioned a link to stress.
Yeah, that's interesting. They're actually innervated by sympathetic nerve fibers. This might be the connection explaining why, stress can sometimes make skin conditions like acne or eczema flare up. It suggests our nervous system can directly influence skin immunity.
Huh. Okay, one more epidermal cell. The Merkel cell.
Merkel cells. They're also in the basal layer, usually associated with a sensory nerve ending, forming what's called a Merkel disc.
And their function.
They're sensory receptors, specifically for touch. They're slowly adapting, which means they keep firing signals as long as the pressure is there. They give us information about sustained, light touch and texture, really important on fingertips, for example.
Okay, we've thoroughly covered the epidermis. Let's drop down now into the dermis. This is the support layer, right?
Exactly. It provides all the structural support nutrition for the epidermis above it. It's mainly composed of tough collagen fibers for strength and elastic fibers for flexibility. And it's where you find all the blood vessels, nerves, and the skin appendages like hair follicles and glands.
And it has layers, too.
It does. The upper layer is the papillary dermis. It has these finger-like projections, the dermal papillae, that push up into the epidermis. These contain capillary loops that deliver nutrients via diffusion to the avascular epidermis.
Okay, nourishing the layer above. And below that?
Below that is the much thicker reticular dermis. This is a dense, interwoven meshwork of thick collagen bundles and larger elastic fibers. This layer really gives the skin its toughness and resilience.
Now, the dermis is packed with sensory nerves. We have the basic free nerve endings for pain and temperature, but what about those specialized receptors, the corpuscles? They can be a bit confusing.
Yeah, it can seem like just a list of names. Let's try to make it clear. So besides the free nerve endings, you have these encapsulated ones. The biggest are the Pacinian corpuscles. Think of them like an onion under the microscope.
Okay.
They respond to deep pressure and high-frequency vibration. They adapt rapidly, meaning they fire when the pressure starts or changes, but not if it's constant. So you feel the initial push or the vibration like a phone buzzing in your pocket.
Got it. What about lighter touch?
For light touch, especially on sensitive areas like fingertips, you have Meissner corpuscles. They're also rapidly adapting, so they detect the initial contact or movement across the skin.
And for pressure that stays?
That's where Ruffini corpuscles come in. They're deeper, and they're slowly adapting. They signal sustained pressure, stretch, and torque, like when you're gripping something firmly or your skin is being stretched.
That helps differentiate them. The sources also highlighted special blood vessels in the dermis for temperature control.
Yes, the arteriovenous anastomosis. These are basically shunts, direct connections between small arteries and veins that bypass the capillary beds right at the skin surface.
Why bypass the capillaries?
For temperature regulation.
Yeah.
If your body needs to lose heat, these shunts constrict, forcing blood into the surface capillaries where heat can radiate away. If you need to conserve heat, the shunts open wide, allowing blood to bypass the surface and stay deeper, keeping your core warm. It's a really efficient system.
Very clever. Okay, and finally, the deepest layer, the subcutaneous tissue, or hypodermis. More than just padding.
Definitely more than just padding, although the fat provides insulation and cushioning. It's loose connective tissue that supports the larger blood vessels and nerves on their way to the dermis. And importantly, it has an immune role too. It contains macrophages that can help fight infections if they get past the upper layers.
Right. Now let's talk about the structures embedded within these layers, the skin appendages. Sweat glands first.
Two main types. Eccrine sweat glands are the most numerous, found pretty much everywhere. They open directly onto the skin surface, and their main job is secreting watery sweat for cooling the body thermoregulation.
And the other type?
The apocrine sweat glands. These are larger, found mainly in the armpits, groin, around the nipples. They usually open into hair follicles, not directly onto the skin.
And they're the ones linked to body odor.
That's right. They secrete a thicker, milky fluid. It's actually odorless initially, but when bacteria on the skin surface break it down, it produces that characteristic body odor.
Okay. What about oil? What produces the skin's natural lubricant?
Those are the sebaceous glands. They're almost always associated with a hair follicle, part of the pilosebaceous unit. They produce an oily, waxy substance called sebum.
And sebum's job?
It lubricates the hair shaft and the skin surface, helping to keep the skin flexible and preventing excessive water loss from the stratum corneum. They're mostly inactive until puberty, when hormones kick them into gear.
Which explains teenage acne sometimes.
Exactly. Hormonal influence is key there.
And hair itself. The sources mention growth cycles.
Right. Hair is basically a shaft of keratinized cells growing out of a follicle. It goes through cycles. Anagen is the active growth phase, which can last for years on your scalp. Catagen is a brief transitional or atrophy phase. And telogen is the resting phase, after which the hair is shed and a new anagen phase begins.
And goosebumps.
The erector pili muscle. It's a tiny muscle attached to the hair follicle. When it contracts due to cold or fear, it pulls the hair upright, causing goosebumps. In furry animals, this traps air for insulation, but in us, it's mostly a vestigial response.
Lastly, the nails.
Nails are just tightly compacted plates of hardened keratin growing continuously from the nail matrix at the base. Like the skin, they're protective, but also they provide a useful window.
How so?
You can assess blood flow and oxygenation by looking at the color of the nail bed underneath, checking for capillary refill time, for instance. It's the quick clinical check.
Okay, we've built a solid picture of the healthy structure. Now let's pivot to the clinical side, connecting this anatomy to the altered health states mentioned in the chapter. First up, lesions and rashes. What's the difference?
It's a useful distinction. A rash is usually described as a temporary eruption on the skin, often widespread. Think measles or an allergic reaction. A lesion, on the other hand, is more specific. It refers to a pathological or traumatic loss or change in tissue structure. It could be a cut, a tumor,
or those mechanically induced ones, like blisters.
Exactly. Blisters are a perfect example of a lesion caused by mechanical stress friction, separating those epidermal layers, specifically around the basement membrane, like we talked about, allowing fluid to collect.
And calluses.
A callus is also mechanical. It's the skin thickening up hyperkeratosis in response to chronic pressure or friction. It's a protective adaptation, really. And corns are similar, but they're smaller, more focused, conical thickenings, often on toes where shoes rub intensely.
Makes sense. Now, the symptom that drives people crazy, pruritus, itch. It's not just a skin thing, is it?
No, not at all. While it's obviously common in skin disorders like eczema or hives, severe itch can also be a major symptom of systemic diseases, chronic kidney failure, liver disease with bile buildup, even diabetes or certain cancers.
And the sources emphasize something crucial. Itch isn't just weak pain, right?
Absolute critical point.
Yeah.
For a long time, people thought itch was just a subthreshold pain signal. But we now know it has its own dedicated itch-specific neuronal pathways traveling up the spinal cord to the brain. It's a distinct sensation.
And the relationship between pain and itch is weird.
It is. They seem to antagonize each other. Pain can suppress itch. Think about scratching and itch. The mild pain sensation from scratching temporarily overrides the itch signal. But sometimes, rubbing an itchy area just makes it worse, unlike rubbing a painful area, which often helps.
What chemicals are driving this itch signal, besides histamine from allergies?
Oh, there are many mediators involved now. Tryptase, an enzyme released from mast cells, is a big one. Opioids can surprisingly cause itch, both centrally in the brain and peripherally in the skin. And things like bile salts, accumulating in the skin during liver disease, directly stimulate itch receptors.
So, treating itch must be getting more sophisticated than just antihistamines or calamine lotion.
It is. While basic stuff like keeping the skin moisturized and cool helps, we're seeing more targeted therapies based on these pathways. For instance, altrexone, which blocks opioid receptors, can be really effective for the intense itching associated with jaundice.
And gabapentin.
Yeah, gabapentin, which affects nerve signaling, is used for neuropathic itch, like the kind people get after severe burns. It shows we're moving beyond just treating the symptom to targeting the underlying mechanism.
Let's talk about another common issue. Dry skin or xerosis often gets worse with age.
Yes, partly because as we age, our sweat and sebaceous gland activity tends to decrease naturally, but it's also linked to dehydration of that outermost layer, the stratum corneum, and can be worsened by diseases like diabetes or hypothyroidism, or even just low humidity environments.
And the treatment focuses on restoring that barrier, the 3 M's.
Kind of, yeah. The cornerstone is moisturizing, and the source material implicitly groups them into functions. First, you have emollients. These are typically lotions with fatty acids that help smooth the skin surface and replace some oils. They feel nice, but might not last super long.
Okay. Second.
Humectants. These are ingredients like glycerin, alpha-hydroxy acids, or crucially, urea. They work by actively drawing water up from the deeper layers of the skin into the dry stratum corneum. Very effective.
And the heavy hitters.
Those are the occlusives. Think thick creams, ointments, petroleum jelly. They work by forming a physical barrier on top of the skin, literally blocking water from evaporating. They're often the most effective for really dry skin, especially if applied when the skin is still damp.
Good practical advice. Finally, the chapter touches on skin variations, particularly evaluating darker skin. What are the key considerations?
Well, first, the increased melanin in darker skin provides significant natural protection against UV damage, meaning less photoaging and a lower risk of most skin cancers, which is a major benefit.
But assessment can be harder.
It can be. Classic signs we look for in lighter skin, like redness, erythema, paleness, pallor, or bluish tinge, cyanosis, can be masked or much harder to see because of the pigment.
So what do clinicians look for instead?
Often you rely on other cues. For instance, dryness might appear as an ashen or grayish look on darker skin. And very importantly, changes in pigmentation itself become key signs. After an injury or inflammation, darker skin is more prone to developing areas of either increased pigment, hyperpigmentation, or decreased pigment, hypopigmentation, like in vitiligo. Those color changes are often the most visible sign of an underlying issue. So wrapping this all up, what's the big picture? We've journeyed through the skin, this incredibly complex organ. It's clear it's way more than just a covering. It's our primary defense, a massive sensory input device, and crucial for regulating temperature, fluid balance, even vitamin D synthesis.
We've really traced the life of a keratinocyte, mapped the different sensory inputs, seen how blood flow is managed.
And crucially, linked the normal structure to what happens when things go awry. How a break in the basement membrane leads to a blister, or how systemic issues like liver disease manifest as itch because of specific chemical mediators in the skin.
It really highlights the skin as this dynamic interplay of systems, neurological, immunological, endocrine, all interacting right there at the surface.
Absolutely. And maybe here's a final thought to leave you with, thinking about that complexity, especially with itch. We're seeing new ways to classify chronic pruritus based on the cost, dermatologic, systemic, neurologic, even psychiatric.
Right.
So the question to ponder is, as we get better at objectively measuring both pain and itch, perhaps using standardized scales, how might fully integrating those assessments change how we approach diagnosis? Not just in dermatology, but across medicine. Could it lead to earlier or more accurate diagnoses of underlying systemic problems?
That's a really interesting point about future directions. A lot to think about. Well, thank you for joining us on this deep dive into the structure and function of the skin. We hope you found it valuable.